But what it does is, like for someone like Raul Gupta in West Virginia, is when he starts to see a lot of overdose deaths in Baltimore, he knows that a bad batch of drugs will soon be in West Virginia in about 8 hours, and they can mobilize emergency teams. So that's beginning to come online.
A devastating epidemic.
We just didn't know what to do. We just felt powerless. A parent's worst nightmare, to find my kid not breathing.
He was always very good at telling us, Mom and Dad, everything's gonna be fine. But it wasn't.
Addiction is ruining lives and ending them too soon.
Overdose is the #1 cause of death for people under 50.
We are racing against time. We have the equivalent of a Boeing 737 crashing every single day.
But what causes addiction?
Individuals struggling with addiction are actually battling millions of years of evolution because our brains are exquisitely evolved to seek rewards.
It's those cravings, the inability to stop.
A dangerous cocktail of biology and medicine, made deadlier by a drug 100 times more potent than morphine.
Fentanyl is super toxic. So you get a batch that comes on the street that's a little bit hot, and on those days, it's like bam, somebody's going down, bam, somebody's going down, bam.
But can new treatments offer hope?
We have extremely effective medications that are life-saving. This is a very treatable illness.
The solution to this is for us to embrace addiction as a disease, to bring it within the house of medicine.
People recover from addiction. Nobody is unreclaimable. The only thing that you can't recover from is death.
Addiction on Nova.
So I want to introduce our panel. Down the end is Sarah Holt, who is the Emmy Award-winning producer and director of many films on many networks, including PBS and Nova, and including Addiction. And then Emily Lindemer received her PhD from the MIT Harvard Medical School Joint Division of Health Sciences and Technology. And she is the co-founder of Hey Charlie, an app that focuses on the social and environmental components of recovery. And Peter Chai is an emergency medical medicine physician and medical toxicologist at Brigham and Women's Hospital and Harvard Medical School. And Peter's research focuses on using digital health interventions to detect changes in medication ingestions. We'll hear more about that. Thank you all for being here. So I really want to focus on proposed solutions and treatments this evening. And one of the most provocative solutions was the one we just saw at the end, which is supervised injection sites like Insight in Vancouver. So Sarah, I wanted to ask you why you felt it was so important to include this story, given that this type of program is illegal in the United States right now.
I was really struck in August. The New York Times reported that they picked up 160,000 needles in the Tenderloin district. And I'm thinking, wow, that's a city. San Francisco, Philadelphia, New York, they're cities in the US that have a drug program as severe as Vancouver. But I also felt like it's really clear when they looked at the data, Insight was funded for 3 years to see, would it attract crime, would it increase drug use? You know, how would the program fare? And in fact, it brought down the overdose death rate by 35%. HIV rates dropped, Hep C rates dropped. And it was so clear to me when I was there filming, we could be on the streets where people were overdosing, and it would take 10 to 15 minutes for the emergency crews to come. And you're thinking, wow, these people are experiencing brain damage. And when you're in the clinics, if someone starts to overdose, they were instantly there. When they help people test their drugs for fentanyl, they could decide, all right, there's fentanyl in the drug, maybe I'll take half the dose. And more people aren't using.
Do you want to talk a little bit more about fentanyl?
Yeah, so I mean, sorry, I tried to select, I had 30 minutes of clips, so the film doesn't completely make sense seen in these bizarre clips, but Fentanyl, the equivalent of 2 grains of salt of fentanyl can kill you. And it's basically now in most of Vancouver's drug supply, most of Boston, the East Coast. I mean, the reason when you started hearing about overdose deaths spiking, it's mainly because fentanyl is now being cut into the drug supply. It's extremely deadly.
And it's not only in heroin, right? It's in painkillers
Well, now we're
as well.
seeing it starting to come into cocaine. There were overdoses in New Haven this fall with synthetic marijuana and fentanyl. It's here to stay. It's cheap. You need so little that you can smuggle it in. You're not talking about kilos. You're talking about a sugar packet that could kill 100,000 people. So it has changed the game. That's one reason it's made using any opioid, especially, so dangerous. And that's why I start to feel like, these supervised injection sites make people uncomfortable. But the reality is we are in a crisis. We have, I think, almost 72,000 Americans died last year of a drug overdose. Fentanyl overdoses are way up. And I think we have to be practical. These sites steer people towards treatment. They keep people safe, and they save taxpayers money.
So there's a section, I don't think you showed it, with the police in Vancouver, and you interviewed the police officers there, right?
Yeah, I went out with the police officers who'd been totally against supervised injection sites, and they said, they could no longer be against it because they could see the overdose deaths were falling. It didn't increase crime. It wasn't a magnet for drug use. And on the downtown east side, they have, I think, about between 3,000 to 6,000 intravenous drug users. So Insight is almost an entry point for helping people find housing, get into the Canadian Health Service. They always offer treatment if you want it. So I think it's a useful program, not for it's not a program for every place, but for cities like the Tenderloin in San Francisco.
Where there's a very high density.
Yeah. It was
abuse.
vetoed here in Massachusetts, but they tried for a while to open one because so many people were dying of overdoses in the bathrooms down around Boston Medical Center. And you may be shocked to know, when I was talking to the EMS crews here, I was trying to figure out where I might be shooting overdoses, and I spoke to them in, I think, August. And so far in 2017, they'd already responded to 3,000 overdoses, just between January and August.
Just in Boston?
Just in Boston. Wow. In Vancouver, they responded to 6,000 overdoses just on the downtown east side last year. That's a 10 square block radius.
So in terms of harm reduction in the US, there is a scene in the film with Dr. Gupta in West Virginia, and do you want to describe the kinds of things he was doing in West Virginia?
So one of the scenes, we go out with Dr. Gupta in West Virginia to try to distribute free needles, because West Virginia is also ground zero, not just for the opioid overdose death rate, but for Hep C and HIV. They're worried about a new outbreak. And so they were trying to go to McDowell County, which has an overdose death rate 7 times the national average, and do Hep C testing, HIV testing, and provide needles, provide Narcan. But these programs are being shut down. Like Charleston just shut down its needle exchange program. I think Orange County, I was just reading today, shut down a needle exchange program. You'd think we know steps that save lives, save money, keep people safe, stop the spread of disease. What's the reaction? Let's not do it. That's the reaction in this country.
Okay, I want to talk about medication-assisted treatment in a little bit, but first I want to talk to Peter and Emily a little bit. So, Peter, I understand that you work with a digital pill. Can you describe what a digital pill is and what does it do?
Sure. So, part of our research, we look at the opioid epidemic from, I think, a lot of different lenses. And one of the things that we don't really talk about is that there's this whole world of exposure to opioids, right? So an exposure to even one dose of an opioid puts someone at risk of long-term non-medical use at 1 year. So one of our questions as researchers is, there's this huge influx of opioids, but how do we prevent exposure, and how do we safely treat people? Because I mean, the answer to the epidemic is not to stop prescribing opioids, right? because we're going to have pain and we need to treat it. It's about how do we do it safely. And one of these technologies that we've used is a digital pill. So it's a gelatin capsule that we printed a radio frequency circuit on, and we compounded it with oxycodone. And in emergency department patients who have acute pain who need opioids, we can dispense a digitized oxycodone pill. And when people ingest them, their stomach acid, the chloride ions, essentially act as a battery and power this radio frequency circuit. So you get a radio signal every time someone takes one of these medications. And when you think about that, the power there is that we can detect how people are using medications, especially opioids. And the big problem with opioids is that, as physicians, these are probably one of the most powerful medications that we have, right? Because they treat pain, but they also cause an epidemic of addiction. Yet, this is one of the only medications where the onus of dosing is not on the physician, it's on the patient, right? We tell you, take your medication as you see you need it. But we don't do that with chemotherapeutics, with antibiotics, it's just with opioids. So this is a technology in which we're hoping that we can detect how people use opioids, and we can detect dangerous patterns of use. So potentially escalation of opioid use, that may be an indication that tolerance has set on. And wouldn't it be great that if we can use these technologies to detect this, we can push forward the interventions and the behavioral science that we know works to help treat opioid addiction. Let's try to prevent that from happening using these kinds of technologies.
So does the pill actually sit in your stomach and stay there, or nothing stays? What happens to the pill?
So it's a gelatin, so it degrades in your body. And then the radio frequency transmitter, it's about the size of a sesame seed, and it's made of a silver alloy, which everybody has a little bit of daily kind of ingestion of that stuff, and it just passes in your stool. So every pill's tagged.
So you have to keep taking them.
Well, I mean, you don't have to keep taking opioids, but you take them, we can detect the change in patterns.
So I'm trying to think of the practical uses.
Sure.
So if someone is maybe supposed to take opioids for a week or 2 weeks, is that the kind of thing that
I'll give you an example. So we have a study where we are enrolling patients who have had spinal fusion surgery. So it's one of the more painful surgeries. And these people are technically, some people will go home with opioids for up to a month. And the question is, what do people really need that much? And how long do you actually have pain after surgery? So by using this technology, we can look at the pattern of use, and we find that people do tend to taper off opioids at some point, probably a lot earlier than we as physicians think they do. But then there's also a group of people who, have the opioids and they start to increase their use. And now, is that a medical problem where there's a failure in the surgery and there's an infection or pain that we need to address, or is that the onset of tolerance? So this gives us a point in which, normally we would wait until a month to see the patient, but now when we detect a change in pattern, that triggers the clinicians to talk to these patients at that time and say, what's going on, and why has opioid use started to increase.
So do you see this as primarily a research tool, or do you see this as having a regular place in the policy of prescription opioids or other drugs?
I see it as both. So from a research perspective, I think it's helpful in helping clinicians develop guidelines for, what is an appropriate dose of opioid for a specific condition? How much do we need to give, and more importantly, what kind of anticipatory guidance can we give patients? So, if you broke your ankle and you're on opioids, can we tell you what the expected pattern of pain medication use is? On the other side, if we have kind of some psychosocial screening that we do in patients that can help us kind of predict a semblance of who may be, I guess, at higher risk of developing opioid addiction. And I think in those patients, that's where the technology has real power, because we know you're at high risk, but at the same time, we still want to treat the pain. So can we do it safely and do it without preventing someone from developing tolerance?
I also wondered whether it could play any role with medication-assisted treatment if there's an issue with making sure that people are following their prescription
so
for that.
Adherence to buprenorphine is a very big problem. We happily in the United States, buprenorphine abuse is not as
Which
big
is
of a problem.
which is Suboxone, which is talked about in the
So
film.
Suboxone abuse. So Suboxone is abused in Europe, for example. They're more common drug of abuse. Whereas here in the U.S., oxycodone and these other opioids are more powerful. But the ability to detect adherence to these things in the context of medication adherence is important too.
Yeah. About medication-assisted treatment, Sarah. So some critics say, oh, it's just replacing one addiction for another addiction. It's still addiction. So what did your experts say about that?
Well, the definition of addiction is the compulsive consumption of a drug despite negative consequences. And when you get on Suboxone or methadone and you start going to work and re-engaging with your family or going back to school, you no longer meet the definition of addiction. So just because you're dependent on a substance doesn't mean that you're addicted to it. And I mean, one of the reasons why I really wanted to feature it in the film is that it's really been a game changer, making opioid addiction, ironically, one of the most easily treated addictions now. It's giving people back their lives, and there's such stigma against it. Massachusetts is like leading the way, but in many parts of the country, I mean, you can't find it. And it's like, it would be crazy when they took Marie off the methadone. She goes into acute opioid withdrawal. She relapses, and then she loses her children. I mean, that's tragic, mismanaged, medicated-assisted treatment programs.
And as some of the people you interviewed said, we don't talk about diabetics who are on insulin as being addicted to insulin.
Right, we don't. I mean, the whole language towards people with addiction is, the stigma is, we don't say if someone has a high blood sugar that they're sugar abusers. And yet we continually stigmatize people with addiction. We make it really hard for them to get treatment, and especially treatments that work. There's a lot of ineffective treatment in this country.
So for people who are in recovery, let's talk. Hey Charlie. So Emily, what is Hey Charlie? And how did you come to develop it?
So Hey Charlie is a mobile technology that we've developed that really helps people with social rebuilding when they're in recovery. So backstory to Hey Charlie. Charlie is my brother, and he has been in and out of recovery for heroin addiction for over 8 years now. And it was kind of said explicitly in the film that when you go to the emergency room and you overdose, they give you Narcan and then they send you back out. And we don't actually treat this as a chronic illness that has a lifelong process of recovery that needs to be supported. And when I'm very close with my brother, and I was watching these cycles of relapse, recover, and there was this thing that I always saw that was relatively untouchable by the healthcare system, and that was that he would be in recovery and seemingly doing great, and the wrong person would drive up the driveway to give him a ride. The wrong person would start texting him and calling him, and it was like to a T. You could predict he was going to relapse, and he would every single time. And I really started thinking about this, like, is this something that we can do something about? Maybe doctors can't prescribe a pill to make you change who your friends are, but can we use technology maybe to help people regain the autonomy to make better choices about how they interact with their environment? And so we developed Hey Charlie as a technology that just runs passively in the background of somebody's phone. And we have the ability to kind of determine the riskiness of things in your environment. So how risky are the people you're talking to? How positive are they? How risky are the places you're going? How positive are they? And when you're engaging in things that aren't good for your recovery, we're not going to call the police, we're not going to tell your parents, but we're going to give you a tiny little nudge that says, is this a good idea right now? Are you sure you want to do this? And every single time we'll just keep nudging you and give you alternative strategies. And our philosophy really is that if you only listen to 5% of those nudges on day one, maybe on day two you'll listen to 10%. And eventually the number of triggers that are in the world that you are living in will go down. And so we're really focused on kind of capturing that environmental, social data to give people back that autonomy in this lifelong recovery process, and then also try to learn what we can kind of from that data to give back to the treatment providers and policymakers to tell them how they can better restructure social and environmental components of recovery.
So I'm really curious about what your strategy is, because your app really depends on people informing the app of what are their biggest vulnerabilities. What are the things that could make them relapse? And how do you get that information out of them, again, without stigmatizing the situation?
Right. So our kind of whole philosophy is that we're a friend on your shoulder. So we are acutely aware of how stigmatizing addiction can be. And so when you onboard with Hey Charlie, we ask you some questions about people that you frequently communicate with through your phone, places you frequently travel. And we don't ask you stigmatizing questions about them. We ask you very objective questions that come from behavioral science research. So there's a tremendous amount of research that shows that there are specific aspects of relationships that contribute to staying in recovery. So if your closest relationship is somebody who doesn't add stress to your life, is someone who tells you, I know you can do this, I know it's hard, you're actually going to have a much different outcome than if your closest relationship is someone who stresses you out. And so we have kind of devised a way using machine learning to understand from the answers to these questions just how risky someone is. We also actually do offer people the ability to say up front, I know this person's bad for me, or I know this place is bad for me. And in the clinical pilots we've done, it's actually been very surprising. Over 70% of people that we've worked with have been very upfront. I know this person's bad for me. And I think that's a really big misconception too about addiction, is this idea that people don't want to get better and that people don't know what their own challenges are. Most people are begging for something that will help them and for someone who will listen and believe that they are capable of making some of their own choices.
So where are you right now with the app? Is it available to everybody, or?
Yeah, so the app is
situation?
free for download on the Google Play Store. We're only in Android right now, and we are doing some larger clinical pilots in Boston as well as in New York, where we start to kind of look at the population level data that we can collect and inform the organizations that we're piloting with, how to utilize their recovery coaches better and their peer supports and things like that.
I think it's really interesting that this touches on this, this notion of community and personal relationships. We're Nova, we're a science show, and we wanted to focus on the science. But Sarah, do you want to speak a little bit about just your experience and what you've seen, across the country in terms of what recovery means and what's necessary for people to recover? Is it just the Suboxone alone?
No. I mean, I think that what the Suboxone does for people with opioid use disorder is it takes away the cravings. So they're out of that horrible cycle of craving, using, crashing, binging. It normalizes their dopamine levels. But after that, it's really important to have good therapy, good community. I mean, people with addiction are shunned, and what we really need to be doing is enveloping them with support. And of course, the memories of using are so powerful. You never forget addictive behavior. They're some of the most powerful experiences you can have. And what's interesting about your app is a lot of people will say to me that, a trigger came into their brain. They had no idea where it came from, and they'd be overwhelmed with cravings. So when you're on something like Suboxone, it seems to stop those cravings. But people eventually go off Suboxone once they get their lives back. Once they're doing better, so it's really important. I think it's an interesting app because, just like with obesity, when you lose weight, it's about lifestyle choices. You've got to change your life to stay in recovery.
One thing that I think applies to both of you in these kinds of technologies, when I hear about an app where I've basically revealed all my weaknesses, how do you make sure that's very personal and also kind of dangerous information? How do you make sure that that's secure and that it's not going to get out? And same, Peter, you can speak to, how do you make sure that your digital pill isn't, that information isn't going to go where it shouldn't go?
Yeah, so for us, we take security extremely seriously. And so what we actually do is we encrypt everything that you tell us at the level of your own phone. So, and it's this type of encryption that once any data gets sent up to us is irreversible. So the only way that somebody could ever know, oh, I said a certain thing about a certain contact, is if they stole your phone or you lost your phone and they knew your password, similarly to if they could log into your bank account through your phone. So it's kind of the same level of security that you'd expect from all of the other pieces of data that you share with apps about yourself.
But do you get data back from the app, and what kind of data do you get, and what kind of information can you glean from that?
Yeah, so we do get data back. So the data that we get back is we can learn on a population level, how frequently do people who are in recovery communicate with risky people? How frequently do they respond to behavioral nudges and decrease their own amount of risky communication? But we never know who the end users are that are having risky communication. We never know who the risky contacts themselves are. We also don't even know where the risky locations are. Even that's encrypted.
Right.
It's all at the level of your phone. So we can kind of glean these population things, which may sound with all this anonymity like it's not valuable. But when we went to one of the clinicians at Boston Medical Center we work with, when we finished our first pilot, we brought him this data and we said, did you know that 70% of your patients are willing to self-identify somebody as risky who was in like their top 10 contacts? He like fell off his chair. He's like, this is something we all know, but there's never been data to support it.
That's great. So how about you, Peter?
So we similarly encrypt everything that we have as well, but we essentially kind of anonymize the data too, so people are not assigned names that are tied to the pills. The pills are just, they're coded with just numbers. So, if anyone got a hold of the data, they just have a series of numbers and times, but no linkage to patients, no linkage to drug type or dosing. So that's kind of how we get around I guess that's how we address security for opioids.
Okay. So then I think finally I want to talk about accessibility. I think, Sarah, you can speak to just even without this kind of technology, there's an accessibility issue about treatment for people who need help.
I mean, the statistics say that 90% of people in this country who need treatment don't get it.
90%?
90% don't have access to treatment. I mean, addiction in most parts of the country is not covered under your normal medical insurance. I mean, when you look at Mary Winnefeld, here's, the wife of an admiral and, one of the most powerful men in the US military, and she's on the computer trying to figure out how to help her son. If her son had cancer, a doctor would be beside her, planning out her care. And of course, when you just go online and look at the millions of recovery places, it's really hard to know who's good. I mean, you pick up the phone and call, you start hearing prices of $30,000 a month, $60,000 a month, $40,000 a month. You ask them for what's their record of success. It's like self-reported, and you can't judge the statistics. And most of the treatment out there isn't based on evidence. It's mainly 12-step abstinence.
Do you know where is treatment available? In terms of the emergency room treatment and response? Is
a handful of emergency rooms now, if you come in from an overdose, like at Mass General, will provide you Suboxone and try to connect you with a provider. But I've even been in, like in Cambridge, and places where I've heard women that worked at doctors' offices who prescribed Suboxone telling me, I always prided myself on calling back patients, and I have so many people calling up wanting a provider, and we cannot help them. There is a shortage of providers in this country, not just of medicines like Suboxone, but addiction doctors.
Are there some programs is there legislation to try to get more providers?
Things are slowly changing and changing for the better. And there is some initial funding. People are expanding Medicaid, and the government now is finally funding medicated assisted treatment. So things are slowly changing, but the death rate is really, last year was the highest number of overdose deaths we've ever had. And where it's beginning to drop are the places, like in Massachusetts, just a tiny bit, that have embraced medicated assisted treatment, that really have a more progressive view. You're beginning to see the numbers come down.
So, and how about for you guys in terms of accessibility? How can we address this with this kind of technology? It sounds intriguing. It sounds like it could be really helpful.
Yeah, so I mean, for us, that's why we put the app out for free. That's 90% of people who don't get treatment is exactly why. We know we're not going to cure addiction with this, but there just aren't enough free resources for people. So doing things like this, just kind of putting things out there that are available to people, I think. But yeah, I mean, it's pretty, I would say, like, it's pretty shocking. I've seen my own brother, like, go and overdose, and they sent him home with a pamphlet that's like, here's this number you call. Like, can you imagine if someone did that to you after you had a heart attack? It's shocking. So I think really it's not even just the availability of resources, but the awareness. Like, how do we tell more people that these things exist?
Yeah. How about you, Peter?
I guess from a clinical perspective, so I work in the emergency department, and at Brigham we also have a bridge program. So we, all of us as physicians are, the interesting part about Suboxone and methadone is when you look at the history of it in the United States, we've essentially called addiction a legal problem, not a medical problem. And I think that's part of the genesis of this issue is, as a physician that can't prescribe methadone for opioid addiction, you have to go to a center, and you have to go through 8 hours of extra training to prescribe Suboxone. And then you can only be waivered to treat a certain amount of patients. And so there's all these kind of legal limits because addiction has always been a legal problem in our country. It's never been a medical problem. And as physicians, it's very hard to bridge that gap because although we want to offer treatment and we want to help, there are often no resources. There are no physicians to treat people. There are no recovery centers that are accepting patients at that time. So at the Brigham, we now, as of I think a few months ago, we now have a bridge program where we offer initiation of Suboxone in the emergency department, and they get linked to a clinician within 24 hours in our bridge program. So I think we're making strides. I think in terms of accessibility, it's important to know that medication-assisted treatment isn't the answer, and behavioral therapy is also not the answer. It's the combination of both that is the most important. And then I think the last thing is people come to us and say, well, I failed treatment because I relapsed. But, addiction is a disease, and part of the disease is to relapse. It's expected that's going to happen. And I think a lot of clinicians we haven't kind of wrapped our minds around that, people want to treat people with Suboxone and then never see them use again. But that's just not possible, and it's not appropriate to treat people like that.
And the other thing I'll say too about technology, one thing that we've learned really a lot about this whole space is just how fragmented it is. So care is so siloed. Like social workers, case managers, recovery coaches, clinicians, none of them talk to each other. Where are the available beds? Like you're in the emergency room, you just got out of an overdose, you want to get treatment for like this 6-hour window when you're really motivated. If there's no bed available, you lose that. And that's something that we've really learned is that it's really hard to mobilize these resources when they exist completely independent of each other. And using technology to kind of stitch some of that to get people that access right away, I think is also something that should really be focused on.
One other point, Sarah, maybe you could talk about the HIDA map.
Right. One thing I just like to say, in Canada, you can pick up methadone at a pharmacy. You don't have to go to a clinic. You can pick it up at a pharmacy when it suits you, and if you miss your dose, they will deliver it to you. The same thing with Suboxone. We weren't able to, I didn't include it in the 30 minutes of clips, but there is a overdose map that is being developed for different parts of the country to track overdoses in real time as they are occurring. And the first time someone showed me the map, I was kind of astounded because you'd get to the Baltimore area and it was just like red. I mean, so many overdoses. It was just like a sea of color.
And it's entered in by first responders, the police and EMTs.
But what it does is, like for someone like Raul Gupta in West Virginia, is when he starts to see a lot of overdose deaths in Baltimore, he knows that a bad batch of drugs will soon be in West Virginia in about 8 hours, and they can mobilize emergency teams. So that's beginning to come online.
Yeah. I mean, then if you get a chance to check out the interactive that we did in Buffalo, they were making use of it's the high intensity drug trafficking areas map, which chronicles where these overdoses are happening in real time and indicates whether it was a fatal overdose or someone survived.
It's a sobering map because you realize when you look at that, there are a huge number of overdoses happening every day in this country, across the country.
Okay. Well, it's really interesting. Thank you so much for this discussion. And if there are questions from the audience?
I'm wondering how, once you do everything after the addiction and stuff, they come off of the Suboxone, right? And then now they have full-time employment, but in their minds, they're saying, I need to take 2 weeks off somehow so that they can just detox from the Suboxone. So when they come all the way down to the level where we need them, what do we do then? Like how do we get them to off it, you know? Because by that time, they're probably still buying it off the streets, or trying to at least.
I mean, I think that when people get prescriptions of Suboxone, they're often on it. I mean, the average time is 3 to 4 years. And they really stabilize their lives. And if they decide to come off of it, I think it's a very, very slow taper. And they just keep functioning. I think it's, you can detox from Suboxone over a year. It's a very, very, and the same thing with methadone.
And
It's
some
not
people
like
stay
you
on
just-
it longer.
And there are
right?
people that stay on it for the rest of their lives.
You
They-
think of addiction as a chronic disease. People who are diabetics don't wean off of insulin at 4 years after they're diagnosed. I mean, we don't need to expect people who have addiction to stop taking Suboxone. It's part of the treatment for the disease of addiction, and it continues for your life.
Yeah.
So some people can taper off, but some people stay on it. And the important thing is that they're functional.
Yeah.
Peter, how is the data taken off of the pill? Is that done in real time or when it passes?
The data is done in real time. So the chloride ions basically power this battery that generates the radio signal, and we pick that up. It's within seconds of all that happens.
So there are little radio signals coming out
Yeah.
from your gut.
And does that patient need to be in your clinic, in your facility to pick up that signal, or can they do this at home and
No,
still?
so they go home with a little kind of receiver that
Okay.
needs to be within 3 feet of them. So most people have the behavior of taking their medications in one spot in the home, and most of our patients have said, I take my medications in my bathroom, so I just leave it there, or I'm going out and I know I'm going to take something at some point, so I leave it in my pocket or something like that.
And then does that then transmit it back
Yeah,
to you?
so it acts as a storage device, so it stores the data, but it also transmits to us as well.
One of the ways that it seemed like, I love your app, by the way, the Hey Charlie. I love that idea. And I think expanding on that and including not just addictive individuals, but sort of expanding that to like the whole world, of helping people identify the things that cause problems for them, and then their goals and the things that help them, so that they can navigate and actually have like a little navigation thing in front of them, so that when they come to a transition point, they can say, oh, I can do that, and that will lead to such and such maybe, or I can do this and that'll lead to such and such, and having that is a far more generic app for everyone to use. And it's kind of similar. I don't know if you've ever seen Jane McGonigal. She did a TED Talk. She's a game designer, but she did a program called Supervised, and incorporating something like that into something. Her program was very intense, but something that was much more simple. Identifying your superpowers and identifying your goals and that kind of thing. So yeah.
What do you think, Emily? Can you just
Thank
help
you.
us
Yeah, thank
solve
you for
all our
saying
problems?
that. Well, so 2 things. One, yes, Super Butter is amazing. We really like being this very lightweight thing that's running in the back. It's not like over gamified, because there's a lot of that. And so that's why we think it's useful for a lot of people. But what you said, I mean, that's kind of how we see Hey Charlie living on in the long-term future is behavior change in people with addiction is probably the hardest group of people to have behavior change happen in. So if we can do it there, hopefully we can do it in other populations. We talk about, me and my team, my co-founder Vinny's over there, we talk about this idea of micro decisions all the time. Like your entire life is made up of micro decisions to talk to a certain person, go to a certain place, and a lot of the times you're not thinking about them. And if you just maybe had someone to nudge you this way, nudge you that way, you could live a better life. we came out of a hackathon, and one of the judges on our panel, he was like, I don't know, maybe like 60, and he goes, I'm type 2 diabetic. I never thought in my life I would relate to someone with addiction. And you just made me understand, like, oh, if only someone was nudging me every time I opened the fridge, maybe I wouldn't open the fridge so many times. And like, we think about that all the time. This is just about behavior change. And it's hard to do, but if you can do it in this constant, subtle way, maybe it'll work.
Yes.
So maybe this is a good segue. You know, we love predictive measures, right? So hopefully we can take action and prevent something from happening, like the digital pill or the application. I'm curious, like with Hey Charlie, I've heard that there's a lot of correlation between what people search for, whether it's a Google search and things like that. So I'm curious, are you thinking about that as maybe a way of being able to predict some potential bad things from happening? I know there's privacy concerns around this, but I think, is that a source of information that an application could use to predict perhaps improper behavior or something bad about to happen?
Yeah, definitely. We would love to get to a point where we can confidently say we can predict things, integrate information from other technologies as well. It's a great idea. I don't know, a couple months ago, I think I saw that Instagram implemented this API where like, if you use certain hashtags, they'll give you a pop-up that says like, do you need help? And it's all about addiction. And so, yes, totally. I think that right now we're like looking at locations and communication, but there's so much more that people do on their phones that we could learn from too.
Hi, Emily. I loved hearing about your app. It also sounds amazing. I had some questions related to using technology. You used the word stitching together different areas of resources. You said case managers and doctors and social workers often aren't speaking with each other, which is definitely true. I'm wondering if you see an application for Hey Charlie, and if you're working with people who are more at the professional medical level to do some sort of collaboration to integrate it into medical care.
Definitely. We're actually working with an organization in New York right now called Services for the Underserved, doing exactly that. So one of the things that we want to do is we want to implement a system where if I'm Charlie and I'm, you know, living my life, and on Tuesday I'm getting this like really high burden of triggers, like a lot of people that aren't good for me are texting me, we want to implement a system where we can send a nudge to your recovery coach that just says like, call Charlie today. Like today is the day he needs to. And maybe we can do that with the doctor, the caseworker, the social worker, many people that need to be integrated into that path and kind of receive information in real time.
Emily, forgive me if this question's a little wonkish, but I noticed that Hey Charlie is available only on the Google Play Store right now. Is that because of usership, technical, or App Store review process-based reasons, or other considerations?
Yeah, Apple just has a lot more permissions around what you can and can't access. In the beginning, we thought maybe we'll make our own Messenger app, and then we realized a lot less people would use that. So we wanted to work with like native calls and texts, which is easy with Android and not so easy with Apple. But it's in our like 1 year from now plan to go to Apple as well.
I have a question about the causes of the addiction. So I understand that having a lot of pills available was a factor to start the addiction. But why do you think, at a more fundamental level, people feel the need to take opioids? And also, I think cocaine and alcohol addictions are rising. So what happens at the level of the society, at the more fundamental level, that triggers this addiction?
I mean, I think that the opioid crisis is grabbing everyone's attention, but the truth of the matter is we have an addiction crisis in this country. More people die of alcohol poisoning every year, diseases related to cigarette smoking, supermorbid obesity, and what I really think we need to do is build an evidence-based addiction treatment for all addictions. And the thing is that the treatment varies depending on the drugs.
Are you asking that kind of, is there something in our society that is...
So it could be loneliness, it could be depression, it could be trauma, it could be... I think that we're seeing a rise in the disease of despair in this country.
Yeah, I mean, I think, like it was said in the film too, so many people are medicating for depression and other mental health issues. And you know, we were in Cincinnati last week talking to people there, and like Kentucky and Appalachia have been hit really hard, and they were talking a lot about this difference between like filling the gap and closing the gap. And that's, I think, what you're kind of talking about is like, how do you close the gap and just make this not even happen? How do you, instead of treating it once it does happen? But you can probably speak to it more as well. Like, it's a lot of the time underlying mental health.
Yeah, and when you look at opioids, so you know, we in the United States we in the U.S. consume 98% of oxycodone that's produced in the world. That's crazy, right? I mean, I think part of it is a culture in the U.S. and you know, it started in medicine where you know, when we decided that pain was going to be a vital sign and we were going to treat pain, and out of that entire kind of world of treating pain, I think that you know, our culture in the U.S. has become that you know, when there's pain, we deserve treatment, and we deserve treatment with opioids, and that's become integrated into our culture. You look at other countries, and you look at other emergency departments, and so like I have colleagues who work in Japan who say, I've got an entire career and I've never prescribed oxycodone in my life, like. Right, and you look at, you know, I have family in Taiwan and I've worked in the emergency department there. If you fall and you break your hip, you get Tylenol because, yeah, it's gonna hurt when you break a bone. Here in the US, you know, it hurts when you break a bone, so you deserve some fentanyl and morphine and you go home on oxycodone and you get OxyContin. So I think there's a fundamental culture change that needs to happen where we need to just change our expectations of, you know, what does it mean to be in pain, and you know, what is the right treatment for that? And I mean, that's a huge societal problem that we need to tackle.
One of the other stories we did in our reporting and is on our digital site is about dentists and opioids. And dentists have an extremely high rate of prescribing opioids just for, you know, for procedures, for wisdom, and particularly for wisdom tooth removal, which happens to whom? To 17 and 18 and 19-year-olds. And there are studies that show that really the best treatment for that kind of pain is ibuprofen and Tylenol, and that it's more effective. But there is, I mean, Sarah can speak to, I think what you're saying is exactly right, that there's been a basically zero tolerance for pain, that people expect to have no pain at all, have it completely taken away. And in some, we're kind of seeing the result of that.
But I also think that we've lived at a time where there was ruthless just distribution and marketing. I mean, people would tell me in San Francisco, they'd be handing out heroin for free, they'd be handing out fentanyl for free, that people in recovery would say that they would try to walk through a city and drug dealers would target them to try to give them drugs for free. They were delivering heroin across the country like pizza. When the drug cartels moved in, they targeted rural communities, kids that had cell phones, they delivered heroin to your doorstep like pizza. So, you know, these are incredibly addictive substances. We did not evolve to be able to deal with substances this addictive. You never found this on the savannah. I mean, the refined cocaine and fentanyl. So we're encountering something we really aren't equipped to deal with, and we're bombarded with it in a world of mass production, mass marketing, mass distribution, mass advertising.
There's one other thing. I mean, this is kind of totally on the other side, but it's to your question, and I think it's maybe a little bit more positive note to end that discussion on.
Bring us back up.
There are areas of the world called blue zones. They're very small, but they're these areas where people live to be over 100 much more frequently than anyone else. And there are some really interesting studies that have looked at these zones, like why do people live this long? And you think, oh, it's like what they eat, with how they exercise, whatever. And every single one of these zones, they found the same thing, that the number one thing that is making these people live longer is a sense of purpose. It's having friends, having a community, having people who make them feel like they are worth, you know, being alive. So that really gives me a lot of hope, because I think that that's actually a lot easier to try to implement and help people with than, you know, coming up with new drugs and all these things. So that's just my positive note.
Can we end it with that? Quick, okay.
Emily, how's your brother doing?
He's actually doing really well. Thank you so much for asking.
Great. All right, thank you so much. I want to thank the MIT Museum for hosting us, Brinda Muniappan and Jennifer Novotny. I want to thank Draper, who supports NOVA. Thank you so much to the panelists. Thank you to Ralph Bouquet and Gina Veramo, who helped set this up and have tons of information about all our film, how to watch our film, how to have a screening of our film, and all our digital assets. So please check that out. And thank you so much for coming. Good night.